All right, just 1 second. Okay. Okay, so can you guys see this okay? Yeah. Okay, so I'll pretty much give an overview of what's available in California for home and community-based services. And I'm from Justice and Aging, and we're an organization that uses power of law to fight senior poverty by securing access to affordable healthcare and economic security through the courts and also through policy reform and legislation. And to achieve justice in aging, we must acknowledge systemic racism and discrimination, address enduring negative effects of racism, promote access and equity, and recruit and support and retain diverse staff and board. It's something we always start our presentations with. So. And then today we're going to talk about Medi-Cal and community-based services, including both IHSS and statewide programs, and with a focus on HCBS. And then we'll do a quick overview of CalAIM's new home and community-based services like benefits. So Medi-Cal home and community-based services is provided through two mechanisms. One is the state plan. State plan includes in-home supportive services, which we all know, and then home health services. And then through federal waivers, and there's 3 types of federal waivers, and we'll go over what that means. And if this is not clear for anyone or too basic, just maybe alert Jessica in the chat and she can stop me because I can't see I don't know how to see the chat through here, actually. So just let me know. So home and community-based services provided through the Medi-Cal state plan program means that the program is an entitlement program and must be offered to everyone who is eligible for Medi-Cal, meets the Medi-Cal eligibility, and has to be offered statewide, which means that there's no wait lists. HCBS waivers waive Medi-Cal requirements, so they're not an entitlement program and they do not have to be statewide, and often do have wait lists.
Hagar.
Yeah.
I'm sorry to interrupt. There's a kind of a weird background noise.
Oh, okay. Maybe it's my chair. Let me try this.
It might be.
It might be me moving.
I also was going to check. I don't know if it's bothering people or not.
Let me try this and see if it's better.
I see people saying no. So if we can't fix it, that's what
Yeah, I'm still hearing the buzz. It sounds like it's a little fly or something right there, but it's not that bad. But I am hearing it too.
I don't hear it now.
I don't hear it now.
You don't hear it?
Maybe now that she's having a headset.
Yeah.
Yeah, I think
it. Yeah.
Is that
Thank
better?
you.
Okay. And I'll try to not move in my squeaky chair. So I'm gonna sit very stable.
it's not your chair. I think your microphone on your
Yeah,
laptop
it's not your
might be
chair.
dying, but
Oh, okay.
yeah.
Okay, so I'll continue shifting around my chair then. Okay, so the state plan amendment is an agreement between the state and federal government, and it allows both, has a mandatory services, which are the home health services, and those are services that occur in the residence of the recipient, and they're on order by physician, nurse practitioner, and they're part of a care plan that's ordered by the physician or any other qualified practitioner. And they include a variety of things like nursing and home health services and medical supplies and equipment and other things. And this is a mandatory service that must be included in all Medicaid plans in every single state. And then there's other optional services, which if the state decides to take them on, then there's a variety of regulations that say like what are the things that have to be in the program if you take on that service. So IHSS is one of them, and California has been providing IHSS services since 1973. And so, we've had this program, IHSS, and we have to provide it to everyone in the state and to all eligible populations. Waivers, on the other hand, what a waiver means is a program under the, separate from the state plan, and the federal government allows the state to waive a couple of requirements that are included in the state plan. So one of them is comparability, which means that anyone who is eligible for Medi-Cal must receive these services, so that can be waived. So waivers are often limited to particular populations, such as older adults or individuals with intellectual disabilities. There's the AIDS waiver that we'll talk about later, which is only for individuals who are diagnosed with AIDS and HIV. And then statewide-ness, which means that the program has, or the services must be provided statewide. So that can also be waived, which means that a waiver can have caps on enrollment, have wait lists, or be limited to certain geographic areas. And then income and resource for medically needy is also a type of waiver or exemption. So a waiver program can be limited only to individuals who meet the medical needy test. So these are waivers allowed under the 1915C section of the Social Security Code. Assisted living waiver, HCBA waiver, the multi-purpose senior services program, AIDS waiver, and the HCBS for the mentally disabled waiver. So all these are under the 1915C section. So I'll just kind of go over these waivers and who gets them, where can you get them, and sort of like how do you apply. And then if you have a question about a particular waiver, you could feel free to send me an email and I can send you the link. One of the problems with waivers is that in accessing them is that there's no centralized location to find information about them. So you really have to kind of dig into the DHCS website or Department of Aging website to find the correct links and the correct phone numbers for each waiver and how to access or apply. So I decided not to put it in the presentation because it gets too clunky. But if you have any question about a particular one, let me know and I can always send you information on how to access that particular waiver. So the assisted living waiver is for individuals who receive full scope Medi-Cal. It is not for individuals who are on share of cost Medi-Cal. So if you're on share of cost Medi-Cal, you do not you're not eligible for this waiver. It's for individuals over 21 and they must meet nursing level of care. And then recently, through the COVID pandemic, there's been a COVID hotspot priority enrollment. So wherever there's a hotspot, there's priority enrollment there for individuals to get off the wait list. And there's also prioritization for individuals who are trying to move out of institutions into the community. And so the way that the waitlist gets administered is that each care coordination agency that manages that county's waitlist will be given a certain number of spots. 60% of those spots have to go to individuals that are transitioning from institutions to the community, and then 40% are from the individuals in the community that are trying to find assistance through the assisted living waiver. The assisted living waiver includes personal care coordination and other benefits that are provided either in a residential care facility for the elderly or in supportive housing or public subsidized housing. In order to benefit from these services, the individual has to be living in one of the geographic locations that the waiver is approved for. So there's a list here. Individuals can move into those counties in order to receive those benefits. They have to move from a county, for example, that doesn't have it. They'll have to move into a county that is that does provide these services. There was a very long wait list, and California got additional spots to clear the wait list, but it's still very difficult to get off of the wait list, I think, because of the limited amount of beds. So right now there's about 4,900 people on a wait list statewide. And there's about, I believe, 6,500 people that are currently enrolled in the program. The program assessment works on a 5-tier system. So a DHCS, I believe a DHCS nurse, certified nurse comes and does these assessments and places the individual on one of 5 tiers. The first 4 tiers have to apply based on needs. So like what the needs are from the lowest amount of needs to the highest, and the highest includes behavioral based needs, and are more for individuals that have severe behavioral or cognitive impairments. And then the 5th tier is specifically for individuals who have had a traumatic brain injury. And that tier includes pretty extensive behavioral health support.
Okay.
Yeah.
Do you want questions along the way, or do you want us to wait until the end?
We could do questions along that. I'm informal. It's an informal place.
Oh, okay. Well, I have a question, and then if others
Sure.
have questions, please, it sounds like jump in or put it in the chat and I'll flag that. So as far as the wait list, like that's a huge wait list, obviously. Is this not so much an issue of the state setting aside funding, but it's more, I mean, it could partly be that, but it's more about whether there are spots in these facilities or in housing?
That's a really good question. It's actually something I'm currently looking into to figure out what's the cause. My understanding right now is that there is a limitation in beds. There's just not enough. I mean, these are RCFEs. There's a statewide shortage of beds. I think the I want to say the Department of Aging has been talking about like increasing the number of beds. There's a lot of money right now that's been going into building capacity. So I think that a lot of the wait list problem is actually from shortage in beds and care. So that is unfortunate. I mean, there are all these spots that have become available, I believe, in March that are just, I think, not being used right now. It's hard to access. And I think
Okay,
part of it
thank
is
you.
also that built-in structure of the 60%, 40%. I think that creates a bit of difficulty as well, because you gotta, each care coordination agency has to fulfill that 60% move from institutions to the community before they get additional spots. Does that make sense? So like you could get 100 spots allocated to you by DHCS. So 60% of those spots, so 60 beds, have to be allocated to institutional care first before they will get additional spots allocated to them, I believe is how it works.
Okay, thank you. I
Yeah.
personally am a little confused, but I can look into that later.
Okay.
But we have hands up now from Fiona, Annie, and Katie.
I think my question is probably going to be sort of general to all waivers, and it's probably going to be pretty basic. For waivers, obviously not all counties are on this list, and I'm sure not all counties are on the other list. So why is it that only certain counties have certain why is it that only certain counties have certain waivers?
It's a really good question. I think part of it is the whole idea of waivers is to, I think, provide services in areas where they're needed. I mean, that's a theory, where they're needed, but also at the same time limit budget burdens. So it's a way of providing a service without overburdening the state budget from the budget perspective. As far as specifically the assisted living waiver, there's actually right now a move to roll it into the home and community-based alternative waiver. So it's going to become, there's an integration work group working on integrating the two into one waiver, and the HCBA waiver, which I'll talk about next, is statewide. So the assisted living waiver, if it gets rolled into the HCBA waiver, will suddenly become statewide.
Okay.
But yeah, there's a lot of problems with limiting waivers geographically.
Yeah.
Like, first and foremost, disparity, right? Because then you've got only certain
Right.
people able to access these waivers.
And then people have to move, and yeah,
Right.
It just seems cumbersome. But that's good to know about the possibility about it being integrated with HCBA, that it would be statewide. Thanks.
Sure.
My question is, for the full scope Medi-Cal, is it federally full scope Medi-Cal, or are we good with the recent Medi-Cal expansion that as long as they're full scope in the state of California, it doesn't need to be federal?
That's correct.
Okay.
And I think that's because the way that the expansion happened, the specific state rule about that expansion is that a person who is eligible for Medi-Cal based on the expansion is going to be eligible for any Medi-Cal service in the state. So the only difference is that the state would not be getting, as far as I know, what DHS has said is that the state is just not going to ask for federal matching for that population, but they're going to be eligible for any program that anybody else in Medi-Cal would be eligible for.
Okay, great. Thank you.
Mm-hmm. Anybody else? Are we good,
Sorry, I
Jessica?
have a question around the wait. This is Katie.
Yeah.
Oh yeah, hi.
Hi, I have a question around the wait list. Sorry, I don't know why it's echoing, but we'll try. So with regards to the wait list, is the wait list done at the geographic level or is it done at the state level? Because when I'm wondering, like, for example, there could be beds available in Fresno, right? County,
Mhm.
right? And so giving that choice to somebody in Alameda County that's on that wait list, because if you can move, say, hey, if you move to Fresno, which I know we want people to stay in their counties where they live, but if they have a choice, giving them choices, say, hey, we do have availability in Fresno, would you be interested? Because they may have family near there, they may have friends near there. Is that something that is being managed currently, or is all the wait lists at the geographic level? Does that make sense?
It does. That's a really good question. And the answer to that is that the care coordination agencies actually get allocated their own wait list. So each care coordination agency gets a number of spots, and they manage their own wait list. So if you go onto the assisted living waiver website, there'll be like a list. You could find a list there of all the care coordination agencies in the state, and you can go to them and say, hey, what's your wait list? And they will be managing their own wait list and their own wait list numbers. And they have to clear their wait list, but DHCS is kind of like controlling the total number of spots. So once the care coordination agency will place people off their wait list, there'll be more room and then they'll give them more spots. Does that make sense? So it's not like you're not going to be calling the Department of Social Services in a particular county. You're going to have to go directly to the care coordination agency in that county. And some counties have more than one. So that's not great.
Yeah, yeah, I was kind yeah. No, and I guess as a follow-up question, so then a person could be on more than one wait list then, from an individual perspective.
That I'm not sure.
Okay.
Actually, that's a really good question. I mean, I would be curious to know if you could like try to get people on like the San Francisco and the Santa Clara wait list. It's a good question. I would be interested in looking into that. So I'm going to make a note of that and get back to you.
That'd be great. Because I also know we have people that would be interested in moving from the Bay Area up to Sacramento because that's where a lot of their family lives, because that was more affordable than it was
Right.
here. So that might be an opportunity to know that answer, because then we can provide choice and say, hey, if you have family living in Sacramento, we can put you on that list. So that'd be great. Thank you.
I mean, it's also interesting about the assisted living waiver is that you get onto the wait list before your eligibility is actually determined. So you get on that wait list, and then when it's time for you to get off the wait list, then they'll do a Medi-Cal eligibility, and you're only able to get off the wait list once you've met that eligibility criteria. So you could potentially get on a wait list and not be eligible, and then be eligible like a year from now when you get off of the wait list. Or you could be eligible right now and be on the wait list for a year, and a year from now your circumstances changed and suddenly you have a share of cost and you're no longer eligible and you've just been waiting for a year. So it's a little tricky. And then I don't know about the residency requirement, if you have to be a resident of that county when you get onto the wait list. So that's a really good question. Like I recently talked to somebody in Napa County that wanted to move to Sonoma, which has the assisted living waiver. And the question is really like, do they have to move first or can they get onto the wait list first? So I'd have to look into that and get back to you.
Thank you.
Sure. Should we go on? Jessica? We
Yes,
good?
sorry.
Okay, no worries. All right. Okay, so we just went through, these are the services that people can get through assisted living waiver. So personal care services with the ADLs, chore services, companion, medication oversight, programs in a home-like environment, and then the 24-hour direct care of staff, which is provided at the RCFE. All right. So there is also the HCBA waiver, which provides, I would say, services that are not as intense as the assisted living waiver. And I think that's partially the reason that it would be a good integration, because the idea behind it is to provide a wider continuum of care. There is a prioritization for individuals who are receiving 90+ days of care in institutions to receive the HCBA waiver service. And this provides, respite and case management, and habilitation, personal care services, community transition, et cetera. And the HCBA waiver is provided through and administered through the local waiver agency statewide. So it has a smaller wait list. As of August, there were 241 spots, individuals waiting on the wait list, and there are currently 8,000 spots in the state available. The thing about the HCBA waiver that's different than assisted living is HCBA is provided in the individual's home or residence. And so the continuum of care idea is you receive a wider degree of services if you put both waivers together. And then the assisted living waiver allows that additional RCFE setting, whereas HCBA is generally in the person's home. Anyone have questions on this one?
I do. This is Jessica.
Hi.
Oh, but Katie, go first.
Go first. You go first. Your question. Go for it.
Okay, thanks. So I'm very excited about this waiver because I've heard about it only recently, which I'm kind of embarrassed. Like that's partly on me, but it's also like, oh, like this should be much more widely known because it seems so useful. I wanted to ask you if you can say a little bit more about what it can look like in terms of the scope of services, like how many hours can people get in terms of a home care provider, and as far as the wait list, since this is in people's homes, is this just an issue of state funding? Like theoretically, we could advocate to have 9,000 spots instead of 8,000. Is that right?
Yeah, and if you're combining this with an assisted living waiver, and assisted living waiver's got 7,000 and this has 8,000, presumably you're now going to have 15,000 spots for both waivers. And then you're giving people more option as to where they're getting that care. So people can get the same level of care for like a wider variety of services, just in different locations, I think is kind of the idea. Although I will say we only met one time for the integration, so it's going to be kind of a slog. There's going to be a couple more meetings, and then I can update you more on what's going on, like what the direction is. But I think the idea generally is to provide a waiver that creates continuum of care in the community under one waiver instead of like splitting it up into this mess. And then also that would extend the assisted living waiver statewide. As far as hours, I am not sure. I can get back to you as far as the hour limitation. It's interesting because both HCBA and assisted living waiver, I believe, can be used together with IHSS. So you would get your IHSS hours. So like if you've got severe needs and you need protective supervision or whatever, like you still can get your 283 hours of IHSS, which would provide the personal care services. And then you would also be eligible to receive all of these other services as well under the waiver. So it kind of works in combination. Like a lot of waivers don't work together with IHSS, but these two do. And so you can kind of combine where you're getting each service from. But as far as hours, I don't know how many hours they allocate per thing.
That's helpful though. Thank you.
Sure.
Katie?
I know I'm very excited about this waiver too. This is why I have the questions. So I had a quick question around, so this is statewide. So are there, again, I'm newer to this waiver, so trying to understand how this all plays out. Are there certified providers in each county when it's offered statewide, or how is that being rolled out? Because I know like usually there's a network of providers that can provide this service, or is that not the case with this one?
It's all through the local waiver agency.
Okay.
Yeah, so there are providers under the waiver definition. There's like providers that are allowed to provide each kind of service and are certified by DHCS. So DHCS kind of controls that, yeah, part of it. And then the agency is the one that both coordinates the services and coordinates both the allocation of the waiver spots and the services themselves.
And
But
is it at the county level then, or because it's statewide, or again, where's that wait list? Again, I always try to figure out where those wait lists fall from a rollout.
The wait lists are really difficult to find, so I believe the local waiver agencies control them actually,
Yeah.
as far as I know.
In San Francisco, it's the Institute on Aging that
Thank you.
handles this program for us.
Perfect.
Yeah.
Thank you.
Yeah, and I think the Institute on Aging is the local waiver agency for a couple of counties. I think maybe also in Santa Clara.
Oh,
right?
yeah.
Thank you.
That sounds about right.
Are they all, is it like that in all the counties that it's a nonprofit that the county contracts with, or is the local waiver agency sometimes the county itself?
I think that in a couple of counties, let me see if this is in the next. Here it is. So you would submit the waiver application to the waiver agency in most counties, but then in these particular counties, you Alpine, Imperial, et cetera, you actually submit directly to DHCS. So DHCS is the waiver agency for these counties.
Okay.
Otherwise, there are these counties, these waiver agencies that contract with DHCS. So the answer is sometimes. Yeah,
Okay, thank you.
sure. Anyone else? Is this working for you to do the question and answer as we go? Yeah. Is that working, Jessica?
I think this is great. Yeah. And if anyone
Okay.
has trouble putting their Zoom hand up or I'm not seeing you, just unmute and jump in or put it in the chat.
All right. Okay, MSSP. This is for individuals 65 years old and older who are Medi-Cal eligible with a disability and require nursing facility level of care. And it's funny that I forgot to add, I'm sorry, I had kind of a bit of a week and I apparently forgot to write where to apply. But you do have to apply with the county through an MSSP site. And this provides management linkage to different services and can fund some services that people need in order to remain in their home. And the MSSP program has 11,000 spots. I don't know if they have, I wrote available, but I meant in general, there's about 11,000 spots in the state. And I am not sure if there's a wait list for MSSP. Maybe somebody here works with MSSP more would know.
I think it depends on each county. Hagar, this is Edith. Can you guys hear me? Okay,
Yeah.
no buzzing. Yeah, in Santa Clara, our parent agency that does it runs the program too. So some have wait lists. Frankly, in Santa Clara County, currently we don't have wait lists because we've had so much unfortunate turnover. You know, when they pass away. So there's actually, I think, close to 100 slots that are open. So we're looking for more people in Santa Clara County. So if people know of that, but I think it depends on each one. So depending on how many spots each one has, some have waivers, some have wait lists, and some don't.
Great. Yeah, some of this information is very difficult to find because I think it's administered, these programs are administered by different bodies. So there's no like centralized dashboard that tells you all the information for all the waivers. You have to really dig in there.
Right. I'm actually on the DHCS website because I tried to Google to find out from the previous one. And they do state for some of them, but it's not too bad. I'll paste that in there, but it looks pretty good. But it lists several of the waiver ones and it says who to go to. So, but it's not comprehensive.
All right. So here are some of the services for MSSP, which is care management and adult day home. And then I think it's really nice that there's like the home repair and maintenance is really helpful, and then additional in-home support assistance and respite services, transportation, and meal services. So this is a really great program. I think it's been quite successful. And okay, I'm just looking in the chat. Jessica, did you want to read this?
Oh, sure. I just, Edith was saying, like, unfortunately, there's slots because people have passed away. And I was saying, with some of these programs, I think it's actually a really good sign when it's like, oh, people died on this program, because it means that we're getting to the right people, and that we're like programs like this, that means this is the goal, right? Is that people are able to stay in their homes and stay connected to their communities, like right up until they die.
Yeah. And I think there's a lot of work now and like discussion around waiver sufficiency and unmet needs. And my position on it is that the more successful sufficient waiver services are those that actually keep people in their home with like no or very little need for institutional care. So I think like measuring or looking at, how often a person in a particular waiver has to be institutionalized, or has like engagement or contact with a nursing facility or a SNF is really a measure of how successful that waiver is in actually supporting people and living and aging in place. Okay, and then there's the age waiver, which requires a diagnosis of AIDS, HIV, and there's a health status requirement where the health status requires home care. The individual has to be Medi-Cal eligible and certified for nursing facility level of care. And this is a comprehensive case management and direct services waiver that requires a doctor referral, and then the doctor referral will go to the waiver agency. And the agency will connect with services and also provide all of the application eligibility material. So the agency actually handles the entire process from application into the provision of services. And it is technically available statewide, but there are not statewide agencies available. So this one's a little bit of an interesting one. I know like up north, there's like one agency for like 4 counties. So that gets a little tricky, I think, as far as provision of services, because individuals have to be able to get their services somewhere. And if they're very far from the agency, it becomes difficult to get services out to them. And finally, the HCBS-DD waiver is generally actually administered through the regional center, which does the assessment by a qualified provider. And then individuals who get the HCBS waiver can get all services and supports that the regional center provides. And again, individuals can get this waiver if they have full scope Medi-Cal or institutional dimming. They reach level of care for an ICF and then required to qualifying conditions from a list of conditions. And then people on this waiver can't be enrolled in another HCBS waiver and must live in the community. Anyone have questions about this one? And this is interesting just because the regional center is really overseeing both the services and the paying for the services and the contracting with providers. So it's a little bit different. Oh, I see that Katie. Oh, now it's showing me that Katie's raising her hand.
Sorry.
New feature. Hi, Katie.
Hi. Did I wave? Oh my gosh.
It said, oh, you raised your hand. It just
Yeah, I was like, well, I can wave.
wave.
Because sometimes it can recognize when I'm talking my hands, and all of a sudden it pops up like, no, I don't want that, because it can recognize hand gestures now too. So you're like, now crazy. One question I had is, so do all the waivers we discussed require full scope Medi-Cal? Because I know some didn't say that in the description.
Some of them allow for share of cost. Specifically, the assisted living waiver does not apply for individuals with share of cost. So you have to have full scope Medi-Cal with no share of cost for assisted living. Most of them you could have Medi-Cal, and I believe with a share of cost. But I can look specifically at which ones and let you know.
Oh, great, thank you.
All right. So next are the 1115 demonstration waivers and the 1915B waivers. I'm sure most of you are familiar with these, at least somewhat, with CBAS, PACE, California Community Transitions, and Medi-Cal Managed Care Plans. So this is specifically these new Cal-AIM demonstration waivers, HCBS-like benefits, which are community supports and enhanced case management. So CBAS is services provided through a CBAS center. There are a variety of centers of services that are provided in. I think they used to be called adult day healthcare centers. They're now CBAS. They're under the managed care plans. And so in order to participate in CBAS, individuals have to be enrolled in a Medi-Cal managed care plan and be at risk of institutional placement or have severe cognitive impairment and need assistance with 2 activities of daily living. The services at CBAS centers include nursing services, physical, occupational and speech therapy, mental health services. There's therapeutic activities, social services, personal care, nutritional counseling, and then there's also transportation to and from CBAS centers. And the you have to call your area agency on aging to access these services, and the Medi-Cal managed care plans are the ones that actually provide them. And CBAS is present in 28 counties, and there are currently 40,000 participants in CBAS centers. And again, I'm not sure if there's a wait list for this one. With the COVID-19, because CBAS is provided in actual physical centers, due to the public health emergency, a lot of the CBAS centers closed. And so CBAS received the flexibility to provide services at home. And now that flexibility has ended and has been replaced by emergency remote services. So now if there's a public health emergency or a personal emergency, individuals can receive these CBAS center services in their home instead of at the center, which is really great. The way that emergency remote service is supposed to work for personal, as far as I know, for personal emergencies, is if an individual is injured or has some sort of crisis and can't go on a temporary basis to the center, they can continue receiving services in their home. And that actually just got implemented, so that's a new change. Does anyone have questions about CBAS? We're good. All right. And then PACE, I'm sure that most of you know more about PACE than me, but this is for individuals 55 years old and older, needing, again, SNF level of care. And PACE services are provided instead of other care services. So instead of getting your medical services and your healthcare services and your support services through the plan by your provider, you have to get all of those services through your plan. Sorry, my dog is snoring. I'm gonna wake him up. So you can get your services at the PACE Center instead, but that does require individuals to deregister from other care services. And all Medicaid and Medicare services are provided by the PACE Center or the PACE provider. And the service is based on by county and by zip code. So you can find your PACE Center on the IHSS website through based on your zip code. All right. Anyone have questions on this one? All right, and California Community Transitions. This is California's Money Follow the Person demonstration waiver. This waiver is intended to assist individuals who are in institutions but would like to and are capable of moving to the community. The requirement is that the individual has been 60 days or more in a SNF hospital or nursing facility and is able to safely transition to the community with support, and it is through Medi-Cal. The service should be coordinating housing and then additional support services, including IHSS and other waivers, and provide home modifications, provide post-discharge case management, and at times I also heard that people have been able to get, security deposits and things like that in order to be able to actually move into a community home. And there's a lead CCT organization for each service area, and that is also on the DHCS website. And what we do see with the numbers of people actually able to use CCT are very small. And I think it's quite difficult, like people are not getting evaluated for them. And I think maybe the bureaucracy part of it is also quite difficult. So there's not enough people actually using CCT to transition into their homes and into homes or into the community from nursing care. I don't know if anyone on the call here has experience with this one that can speak to it, but I think it's an underutilized program that really we should think about how to access more, especially given the Laguna Honda situation. Be an appropriate program to use.
Hagar, when you said underutilized, do you have a sense of how many people use it and what counties? Is there information available?
Yeah, there is. I just didn't have a chance to look at it, but the last number I saw was really, really low. I think there's a map that actually shows you the distribution. It's like very few people actually able to use it, or not able, or have it all used it. I'm not sure. Like if you talk to I talked to somebody who works with this program and said it's just like very difficult to use. So I think it takes a very long time from the moment that you identify the person to actually being able to move them. I'm very sorry about my animals. I think they do this on every call, every IHSS task force meeting.
I think we love it. And Edith has her hand up. Sorry, Edith.
Sure.
Yeah, I've not heard of this, so I have a couple of questions. So, is there an age limitation to this one in terms of eligibility?
I believe 18. I think
Okay.
if we, yeah, I believe it's
Okay,
18.
so it could be disabled, disabled young adults. Okay,
Yeah.
and then what was my other question? I forgot what it was. Sorry. I was so
Oh, no worries.
eagerly saying, well, my question was sort of related to Jessica's, how many people are on this and things like that. And so that's okay. We can look it up, but I didn't know anything about it. But it sounds like it's low utilization because it's so difficult to navigate or
Potentially. I mean, there's also the question of like who's identifying potential individuals, right? So like there's not an external person that's going into facilities and identifying individuals that could use this program. So it's either going to come from the person themselves, and I think a person inside who is currently in an institution probably has a difficult time accessing that kind of information or even knowing about it,
right.
or family members, or a social worker or an individual within the facility. And I suspect that there's very little motivation for an individual in a facility to like actually access this program and help people out. So
right.
I think there's a lot, like there's room for us as advocates, I think, to educate more people and sort of like try to access this program more. I think there's also the question, and I wonder how much of this is related when people are in facilities, they have that home maintenance amount, most of their money is going to go to the facility, they're going to lose their house. I mean, we all know, right? When people go to facility, they lose the ability to come out and keep their housing while they're in a facility.
While they're in there, right.
Yeah.
So
then where are you going to go? And then
right. If you have no home and then you have to wait for some housing, related things. So yeah, I guess I can see how.
So I think that really, really stretches also the number. The program is supposed to help people also find the housing. But if there's no housing, which we all know there isn't, it's a bad situation. And I'm not sure without additional, very zealous support, how practical it is to use this program. You need actual advocates that are willing to make this happen. And maybe part of it is linking individuals in facilities with a CCT organization to kind of make that happen. Because I think once that linkage happens, probably things move along a little bit more.
Right. Okay, thank you.
Sure.
And this is Jessica again. If I can just add on to that, like one real challenge that I'm seeing in talking to folks at Laguna Honda specifically is that with using CCT or using really any of these is for people who are institutionalized for a long time, people not only do not know the programs, but they don't have a vision of like what's possible in terms of living in the community with a significant disability and what it looks like to get the supports you need. And so, I mean, I don't know if that conversation happens here or elsewhere, but I think there's some questions for me about how do we make sure people hear from people about like what's possible, right? And ideally to connect with people with disabilities who are living in the community, people who are using some of these programs, so that we're not relying on someone to say, yes, I want to do this before we talk to them about it.
I mean, I think that's a good question. I mean, there is a freedom of choice provision, and I've been thinking about this a lot lately. Like when you enroll in a waiver, you have to sign a freedom of choice paper that says, yes, I'm choosing to do this waiver instead of living in institutional care. And I'm wondering, to what degree do we want that freedom of choice to also apply when someone is being put in institutional care? It's like, yeah, I want to get into institutional care, as opposed to getting that support on the outside in my community, and sort of filling in that piece, that educational piece at the front end, so that people are more aware of what supports are available and what's possible. That's a really heavy lift, right? It's like a pretty heavy educational lift, both on advocate side and probably on the state side. I don't know what you think of it. I don't have a great answer for you, but that's kind of, there's a lot there. There's a lot of opportunity for education, both for consumers and for advocates, to sort of go out there and make sure that people know what's available and what's possible.
Yeah, I love that. Thank you. Oh, Fiona?
I'm just going to follow up. I mean, are there, it sounds to me like to implement what you're talking about, Jessica, we need to find folks that have gone through these certain waivers. And I don't I don't know where to find these folks. I know, for example, a lot of times ILCs are independent living centers are the CCT organizations for an area. We are not, but a lot of times they are. So they might have at least CCT success stories, but I just where would we find the others? I mean I don't know.
Yeah, I mean, you'd have to kind of reach out to these to the agencies, I think, that administer them. And then there's always the advocates, like DRC, I think, does a lot of work with waivers. So they would
Yeah.
probably, right, they would probably have an idea on how to go about it. But yeah, it's not easy. I'm working on a policy paper right now that's kind of dealing with inequities in HCBS, and I'll tell you, like, one of the very basic things I think that's needed is just centralized information.
Yeah.
Like one place where you can find all the information about all the options that you have and what those options come with. I mean, we have
Yeah.
the California exchange, right? The exchange system for healthcare, where you can go on there and put all your information down, and then it pops back out for you, like, what are you eligible for
Yeah.
healthcare? I'm envisioning that with HCBS. Like, I'm meeting level of care, nursing home level of care with the following needs. Like, what can I get, and what is it going to give me?
Yeah.
I completely agree with you. I think that that was one of the pieces of information that one of our IHSS recipients, who's now the chair of our board, said, had I known what my other options were, I would have made different choices. And they found it very difficult to navigate. And I've been saying the same thing. It's like, can I put in what my elements are and see what I qualify for at so many levels, you know? I mean, there isn't, you think that we developed something like that, right? That has some logic behind it for all these different kinds of community-based programs. But I think that kind of knowledge base or resource is completely missing.
Yeah.
I mean, Edith put in that website, but even I'm scrolling through the website.
Oh, it's horrible.
That's incomplete. So, I mean, your presentation, Hagar, is more complete than this
I agree.
website, so
I know this really makes me want to just like Hagar, if you're open to sharing the slide deck, like, I kind of want to just put this and all the information on all of our websites as a place to start, you know, like that would be a lot more than what we have already.
Yeah, I can add, if you give me time, I can also add links so that people can kind of go and I just didn't have the chance to do it.
That would be awesome.
The high holidays just messed it up for me.
Yeah.
Yeah, I mean, I think also the state tried in 2013 a universal assessment where you would fill out an assessment for all community-based services, and then you could be assessed for all of them at once, but they never got it done. So because they tried and they said, oh, it was too hard. And part of the reason it was too hard, I think, is because the programs, each of the programs has its own requirements, and one has a share of cost, one doesn't have a share of cost. It was too difficult for the state to somehow get a universal assessment done. I think they should try again, but I think even if you could walk in, the fact that you could walk into a county office and do your IHSS forms, but you can't do that with any HCBS is ridiculous. Like, you should be able to walk into a county office, but you can't. You have to figure out which agency to call and whether that's available in your county, and and then decide which one you're going to apply for. And then you're very limited because you've just gone through this entire process, but only for one waiver. So that's very limiting. Okay. And then,
Dario has a question.
Yeah, I have a comment on the HCBA. We in Marin County, we have a client that I know of that that was accepted to the what's called the waiver personal care services, which I think falls under the HCBA, and she's a quadriplegic, and she gets the max, 283 hours for IHSS. But on top of that, she gets an additional 240 hours with this waiver program, and these hours are in the CMIPS program. So they're, the IHSS and WPCA or WPCS hours get claimed in the same system. And so, she gets a total of about 17 hours a day for services, and which I think is great. But I wasn't directly involved in connecting her to this, but from what I understand with some of the social workers, it was a struggle to connect her to these services.
Yeah.
But yeah, I think this is great, and I just I wish I knew more of these, because they're definitely needed.
Yeah. That answers everyone's question about how many hours. So there you go. I think the potential, especially for HCBA and assisted living, where you can get all these supported services on top of the IHSS, can be very powerful, because then you could really, like, IHSS is just not enough, right? Like, people who need intensive care and assistance, like 283 only gets you partway there. So, does anyone else have comments? Should we move on to CalAIM? So CalAIM is being provided, as everyone knows, is being implemented right now, and CalAIM has two HCBS-like benefits. One is the enhanced care management, and the second is community supports. So the enhanced care management is comprehensive whole person care management for populations of focus. So it's really limited to a few populations, and it's being rolled out kind of throughout from, I believe, January 22 to, I think the final rollout is going to happen in July or June of 2023. So you can't get it enhanced care management if you get PACE or HCBS waivers. You have to decide one or the other. It's a new Medi-Cal benefit. It's going to be offered to eligible Medi-Cal managed care members starting in 2022, and it's considered the highest level of case management. It will be offered to the most vulnerable and highest needs plan members, and individuals are going to be screened based on whether they are in these population of focus groups. So initially, ECM was phased in by county, starting with people in the whole person care and health home program, and then later it expanded statewide. So now it's available statewide. And it's primarily an in-person interaction with members where they live, seek care, or prefer to access services. So they'll get the care management in wherever they prefer to get care management, including in their homes. And then in 2023, the population of focus that will be rolled out are justice-involved adults in January and justice-involved youth in June of 2023. Okay, oh, sorry. Edith, your question is, yeah, demonstration waivers generally are more temporary, and then oftentimes they are later rolled into a more permanent one. But like MediConnect was a demonstration waiver, for example, and it ended and is being replaced by CalAIM. Sorry about that. Does anyone have any questions about enhanced care management? All right. And then community supports, I feel like, is the more tricky one. These are there's a list of 14 optional services that Medi-Cal managed care plans can offer. There are the new in lieu of benefits. There are, instead of getting services in an institution or a SNF, these are services that you can get in the community, which include transitional services, housing deposits, respite services, and medically tailored meals, as well as a bunch of other ones. And these are available statewide, but they vary per county because each plan decides which services they want to provide. They can be offered, let's see, I believe the people that are identifying individuals for community supports are supposed to be the plans, and as well as community-based organizations. So there's supposed to be some communication between CBOs who are providing the services and the Medi-Cal managed care plans. The services are going to range from housing transition. I think particularly the housing assistance that community supports provides is very powerful because the intent is to actually to help with housing stabilization and to address difficulty transitioning into housing and stabilized housing. Does anyone have any questions about this program? And that's it. I'll take more questions. I'll stop there. Let me see if I can stop sharing here.
I just want to
Alright.
share a huge thank you for Hagar. Clearly, we were all really enjoying that. And a couple of people put in the chat they had to go, but really want to see the slides later. So thank you for putting that together and sharing it.
Sure.
I feel like we've just scraped the surface now with what we all need to know about and how do we get these programs actually used or expand them where they're needed.
Sure. Yeah, I think it's difficult just because they're so piecemeal and just kind of scattered all over the state. So yeah, if you have any question about your county, like how to get somebody enrolled or where to go, just let me know and I can answer individual questions. It's just a little bit hard because it's so spread out and different around the state. It's a little bit hard to give a presentation and be like, oh, you should go here because it's really varied. So I almost feel like it's better to give a general overview and then answer individual questions later. Hopefully it felt the same. Some of the difficulty also is the form. So like you have to fill out assessments, needs assessments for each program, and all those needs assessments are different. Not all of them are available online. But if you did want to look at one, I think I have at least a few of them. I've collected a few of them. So if you do work with any of these waivers and have a electronic version of a needs assessment, just send it to me because I'm working on a catalog.
Hagar, like I mentioned, we have MSSP, so that one's fairly well known, and I think they have their forms online, so they do a couple of different things. But I would completely agree with you. Thank you for this. This was incredible. I know some of the waivers, but it's just so many of them, and I think, like you said, even if we internally could, develop part of our own thing, but it just seems like everybody's reinventing the wheel by trying to, to help figure out where these things are. You would think that the state would attempt to put something like this together.
Yeah. We'll keep pushing for it.
Yeah.
Yeah. But thank you.
Edith, did you get your question answered from the chat?
Yeah, about what Hagar had said,
Okay.
that the demonstration waivers are normally something that start off as like a pilot or temporary, and then they end up being rolled into something more permanent, or they, find out, okay, that didn't really work. Like, sorry, CCI, right? And all that. It's like, well, let's try this, and it didn't really work, and now it's part of. I think it's some of that stuff got rolled into CalAIM. So when you kept saying plans, you meant the health plans, the managed health plans, right? That was my other question in your
well, it depends when I was talking about it, I guess. As far
it was
as
mostly the community supports one and maybe one other, but when you say
that's
plan,
managed care plans,
right?
Yeah,
right. Okay.
Yeah, and those are tricky. I know. I just went to a conference last week where all the CBOs were really upset about the community supports element, especially. I think it's very difficult to figure out what's available, and then the CBOs are really the ones that are supposed to, like Independent Living Center, I think is one, right, where they're supposed to identify people who are eligible, but then the managed care plan is kind of more top down, and they're supposed to be providing those services. So I think there's going to be a little bit of a bumpy transition.
Yeah.
But hopefully people will work out the kinks, and I'm hoping a lot more people are going to be able to access these services.
I have to say, at least in our county, we already work, with the two. In some counties, they're more fortunate because there's only one health plan to work with,
Yeah.
because, it's either a county-based one, but some have two. And I think some, like Los Angeles, have, 3 or 4. But it can be a little difficult to navigate because, again, I don't want to say this loudly, but health plans sometimes are not looking, they look at the things based on their billable, codes and things like that, where we tend to look, a little bit more holistically about things, or try to. And I'm not saying that they don't, but so many of these things are being passed down at that level. I'm wondering if those things are being lost in some way.
Yeah.
I'm
Yeah.
curious, do any of the counties, and if they've worked with anyone, at least in IHSS, has anyone been, we've been having meetings with at least one of the health plans about some of these enhanced services that they're rolling out that specifically are around, it's not WPCS per se, but maybe it's kind of HCBA like things where they can pay for additional services for IHSS recipients that require more, but it's limited to what they can do. So they've been working with us to try and figure out, how to refer people and, what they can qualify for, but it's pretty confusing, I have to say. It's not it's not the enhanced case management, but it's basically, I guess they call it IHSS-like services.
I think it's the community supports, right? Then the trick with that is that it can't be duplicative. So you
Right.
can get right? So you could get like IHSS, but you can't get the same.
Exactly.
So, yeah.
Yeah, I can't remember. They called it something else. That's what's a little confusing too, but I think it's under community supports, and that's rolling out in January of 2023. Yeah. Okay,
Yeah.
then it must be that. Yeah.
I'm also wondering if folks want to share, are any of you using, or do you know of any of these programs being used in your county? And what does that look like? How is it working? What barriers are you experiencing?
Eileen, do you have any, do you work with any of these or know of them, or that's mainly done under a different department?
It's Tamisha, like looking to you, like.
Yeah, I think it's all through IOA and CLF, so I'd have to get more information.
Yeah. This was a wealth of knowledge.
Yes.
I'm just like, how does anyone navigate this? Like, which we've all just, repeatedly said that this is confusing, but I mean, Hagar definitely did the best of making it as less confusing as possible.
I'm always happy to clarify. It's like a learning process for me too, because it's just, all over the place. So
Yeah, I don't want to keep talking, but I do know about some of them, specifically MSSP, and only because, like I said, our agency, our higher level, our parent agency, is the area agency on aging for Santa Clara, but we don't do some of the other things, like we don't do CVAS, and that's done through, another area. So even there, it's disparate in terms of what any given agency does, because you might be authorized for one thing but not another, or or didn't. So I am familiar with MSSP fairly well, and we have a lot of clients that are in IHSS that we also refer to MSSP if they qualify for it. So I found that very helpful, especially because they have much more interaction from a true case management perspective, because the social workers can't really, IHSS social workers aren't really case managers, right? They do the best they can, but they really don't handle these other things. So we've worked hand in hand with our MSSP counterparts. So that's been very helpful for some of those really case management intensive, needy IHSS folks. And then our case management team, or MSSP team, is also taking on enhanced case management that falls kind of under the same thing. They're developing another unit that's doing that. So we're rolling that out with the 2 health plans that we have locally. But because it's a similar kind of program to what's in MSSP already. So. But as for the other waivers, I can honestly say I didn't know a whole lot about them, so I found that really helpful. I saw your thing, Jessica. I think this is great because this is such a wide range of things. I think it's helpful if we can get other agencies, you know, from different places. Maybe it's not enough for all of them, but we have a speaker that talks about, you know, the community supports, and someone that talks about HCBA, and someone that's done it successfully, and you know, talks about how do you apply and what are all the things that you need there, and you know, just maybe a little resource link. So maybe we get one from each county that can do that, and as a future one. Do you think that's helpful?
I think it would be helpful, yes, to get a better understanding of everything. A lot of these are contracted out to agencies that get the information.
Right.
See how things are going.
Right.
Yeah, that sounds good. And I think I'm a little bit worried, maybe based on what I see in San Francisco, is that like it makes sense to contract things out, you know, because we don't all have capacity, but then are people getting referred in the right places, and do we have the right connections as far as who's coming into contact with people that need these services? So for folks from other counties, Marin, Contra Costa, I'm like, what county is Silicon Valley Independent Living Center in? Is that Santa Clara County?
Santa Clara.
Okay, same county. Would you like to spend another regional task force meeting talking more about these programs, and like Tanisha and Edith said, inviting some folks who are, what are we saying, who are the ones contracted to run these programs from your counties? Would that be useful?
In Marin County, we don't have a PACE center. We do have MSSP. We don't have community-based adult services. So there's things that I feel we need in our county that are lacking. I mean, you know, the largest age group in Marin is older adults over 65 years old. I think it's at 23.5%. So it's definitely things that are needed, but are not available. And I did, you know, we have a large older adult nonprofit, Vivalon, what used to be called Whistle Stop, that provides services, but I don't think they see a PACE center or adult day center as something that's fiscally possible. And so just kind of maybe learning a little bit more and trying to figure out, if other agencies can expand over here, or what we can do to make sure that these services are provided locally in our county.
I think interestingly, like CBAS is a statewide program. It should be. It's more about where the CBAS centers open or stay open. I mean, I think there's only 28 counties represented, but it's thought that they can't be. And they are provided through the managed care plan. So that's maybe a conversation for the managed care plan in Marin County as well.
Okay, well, thanks for that, Dario. And Annie, I saw you nodding that would be useful.
Yeah, I think the hardest part for me is we've lost so much organizational knowledge that there was probably somebody that knew all of this that retired and I'm now senior management and I'm hitting the point where I can't use my I'm new card anymore, so I think anytime we have resources, especially for well, one, as you guys know, providers in IHSS we're always struggling to find them. So if we can find a resource for someone because we weren't able to get them the services they need in IHSS, we can get them the hours, but we can't get them a provider, and there's somewhere else we can tap into. And then for the individuals that we have that our service just isn't enough, and getting that. And I do know of some of our, community-based organizations that we contract out to and do take these. And then we also, I think the other difficulty in San Francisco can probably nod to this is that we rename everything. So our whole person care is Community Connect in Contra Costa. So I might actually know exactly what we're talking about, but because we put our own spin and our uniqueness on it, I'm like, that sounds very familiar to something. So yeah, I definitely appreciate this. And and would love to have more resources that I can provide in an easy grab for my social workers, especially when we're in a position where we just can't get the recipients what they need. Like, how can we service our community the best?
Yeah, it's all about trying to solve those unmet needs, right? We have the same challenge, the exact same challenge. Like, okay, can't get them a provider, but you know they need more. And you know, I for lack of anything better, it's a really good resource directory, and those are so hard to keep up and know. Like, how do you briefly put what the eligibility is, and then worse than that, it's like, okay, I put the requirements, but then how do you go about helping them figure out how to apply and if they actually qualify? I think that that's really one of the biggest challenges, and you keep sort of circling back to that. And maybe that's what we really push for, is like, is there an easier site that does this data gathering?
Yeah. And I think for me, what would be helpful, and I appreciate, Hagar, that you put that in there, is the ones that are IHSS complements and the ones that take over IHSS. I think that is critical for the social work staff when advocating, because we don't, we want to get individuals the best need that they possibly can, but we don't want to come off insensitive or like, oh no, we don't, Contra Costa or county services aren't what you need. We want to make sure that we're doing it in an informed way. I think that that's also a critical piece that would be great in this imaginary booklet checklist thing that we're creating or we're asking for.
I think that's a great point, Annie. I think maybe starting with, because we're in the IHSS world, which one of these, can complement what they do, and start there first and focus on the ones that, we think that they'll get the most need out of, and then also put the other ones, but focus on those that we think, they can generally qualify for the most part.
So we refer people over to PACE knowing that they're no longer going to be our recipients, but
right.
That's a better fit for them. And that's probably the only one that I default to, because that's the one I'm most familiar with my APS counterparts.
Mm-hmm.
This is really helpful for me. I'm supposed to be working in the next year or so on a HCBS primer. So maybe as I work on that, I'll come back and ask you guys what you think. This is really helpful, actually. So I like the idea of having like a complementary IHSS section, like which ones work with versus are supplemented by, or, replace IHSS. It's great.
I have a question. I'm wondering if any of these waivers or future programs that are coming up, maybe through CalAIM, do you see, Hagar, any threat to IHSS, in terms of replacement by these new?
No, I mean, the only threat I see is the provider shortage. I think, well, and then we can talk about reimbursement rates. We could preach to the choir about that, but yeah, I think that is, those are a couple of threats. There's a lot of talking about contract mode, which, is like controversial. Is it going to help IHSS? Is it going to harm IHSS? I don't know where I stand on that yet, but but I think like the number one thing that everyone is feeling, the number one pain, is that there's just not enough providers, and then there's the high needs individuals who have a hard time playing the role of, taking on that role of employer, and I think that's been difficult. I'm sure everybody here knows that. So, but as far as like the HCBS investments, like I don't think that that's a risk. No, mostly because, and ECM I think is limited to a certain number of days a year. You can't get it forever. These benefits are limited. They're under the plan. You're not going to be able to get them. They're not going to replace, I don't think, IHSS. They might be a good transitional service, particularly community supports, as you transition from an institution to your home, and then you need extra support for the first 6 months, and you could get those supports through community supports, but you're going to have to transition to something else after. It's not going to be forever. So that's kind of important to keep in mind, that a lot of these supports are really great as you're stabilizing your clients, helping them like kind of find their bearings and like get used to living at home and finding out what they actually need. And then you can look to these other waivers to see what's more appropriate for holistic assistance at home. Hopefully that makes you feel better.
Makes me feel better. Yes. Thank you.
Well, thank you so much, again, to Hagar and to everyone. Like, I think this is this group at its best, right? Is like being able to hear from different counties about what you're seeing and what's needed. So let's definitely continue this conversation at our next meeting, which I realize I didn't put under other, but we should decide when that is going to be. I'm going to move us to the next piece on the agenda. We just had a couple legislative updates we wanted to talk about. I'll turn it over to Edith actually for the first.
Well, let's see if I can do this. So for those of you that do or didn't know, there was some legislation that was on the docket that did not get